One of the observations that's been made with Ceritinib as well as other second-generation ALK inhibitors is the level of activity in brain metastases. First of all, in general, brain metastases are a very significant issue in lung cancer, and it seems to be particularly significant in ALK-positive lung cancer. It may be that patients with ALK as well as EGFR disease are very sensitive to treatment. They live longer, so they have more time to develop brain metastases. It's still unclear how well these drugs penetrate into the CSF. There's really not been sufficient data to address that sort of aspect of these drugs. And getting back to my previous comments about the potency of this, that maybe Ceritinib seems to have more activity in CNS disease because it's just a better ALK inhibitor. And whatever gets in the CSF or CNS is just more potent at inhibiting the disease, and that's why you seemingly see a higher degree of activity in this particular setting. So certainly that would be a consideration. To me, I would consider Ceritinib in the first-line setting if a patient initially presented with brain metastases. Although many of our brain metastases may be asymptomatic, many of them are well managed with focused radiotherapy techniques. And so perhaps that would be an argument to delay Ceritinib and use Crizotinib first if you're going to treat the brain with radiation therapy. So my experience with the second-generation ALK inhibitors has been both with Ceritinib and Alectinib. And again, this has been largely in patients that were pre-treated with Crizotinib to date. These drugs work. They're well-tolerated oral agents. I think my experience is reflective of what's been reported in the New England Journal paper, as well as what we know about Alectinib so far, that it seems to have an activity level that's similar to Ceritinib. And so it's nice to have that option for patients. Now, you know, one of the issues is how many ALK inhibitors do we really need? And it may be that there may be subsets of the ALK translocated patients that have variations in the gene structure and protein structure that may be better treated with one or the other. But we don't really yet have a clinical database that can guide us to that level of certainty, at least not yet.